Bismillah ar-Rahman ar-Rahim. Our topic today is gonorrhea and syphilis. These both topics are examples of what is called sexually transmitted diseases or sexually transmitted infection. We will start first with the gonorrhea. Gonorrhea in Arabic called salan. What is gonorrhea? Gonorrhea is sexually transmitted disease manifest as urethritis, inflammation of or infection of the urethra, cervicitis, infection of the cervix in the female, proctitis, and conjunctivitis. These all areas, the conjunctiva, the cervix, the urethra, the rectum, all can be affected by the gonorrhea. Gonorrhea can be transmitted from male to female or from female to males, but the transmission from male to female is more efficiently than the opposite direction. And on the same time, it is easily recognized, urethritis is easily recognized by the males than the females. Here we will discuss the clinical manifestation in the male. What is the rate of transmission when only one single unprotected sexual encounter with an infected person? It's very high. It can reach up to 90%. That means where is any sexual contact with patient with gonorrhea, the other one will get gonorrhea in around 90%. That means very, very high. What are the clinical manifestations of gonorrhea? Of course, here we will discuss the urogenital manifestations, but we will also explain that these people can also develop, as I mentioned in the previous slide, they can also develop other areas infection. The main area that is affected by the gonorrhea is the urethra, causing acute urethritis. The incubation period of this bacteria, gonococcus bacteria, between 2 to 7 days. That means when anyone is having gonorrhea, has a sexual intercourse with other one, maximum 7 days, the incubation period. In maximum 7 days, the other person will get the clinical manifestations. If not after 7 days, there is no clinical manifestation, that means that person is not having gonorrhea. And the clinical manifestations, mainly in the males, are very obvious. Characteristic here is the urethral discharge, virulent urethral discharge, pus urethral discharge, and associated with dysuria. This is very characteristic. Virulent urethral discharge. As I mentioned, gonorrhea can not only affect the urethra, it can also affect the rectum in patients who are, or in persons who are homosexual. Pharyngeal gonorrhea can also be a manifestation. We also have to recognize that. Ocular gonorrhea, even manifested as conjunctivitis, but we have here to consider in our topic here is the consideration of acute urethritis. Here This is a typical purulent urethral discharge due to gonococcal urethral infection. Very characteristic. Mainly in the morning when the male patient is getting up, he will note that he is having this purulent spontaneous urethral discharge. Purulent. Very characteristic. Pharyngitis can also be like here in this slide. Conjunctivitis. How to diagnose gonorrhea? In addition to the clinical manifestations in the male, here I will consider the male. In male, gonorrheal urethritis is characteristic and obvious. In the female, it is not so characteristic and it is usually not obvious. The females cannot, not in all time can recognizing that they are having discharge or purulent discharge. Laboratory diagnosis here is by gram staining of the urethral oxidate. Typically, there is gonococcus, and these gonococcus are gram-negative intracellular monococci and diplococci. And this is highly specific and sensitive in diagnosing gonococcal urethritis. There are also rapid tests, nucleic acid amplification test, and also there are probe tests. This all can help us in diagnosing gonorrhea. To start treatment, in suspected patient or in characteristic patient who has purulent discharge, urethral discharge, we should not delay till the culture or the gram stain result is ready. We should start. Of course, we will take the sample and send to the lab, but we must start treatment. And the treatment of gonorrhea is so easy that even with single antibiotic dose, we can solve the problem. Here we have options for the treatment. We have first line regimen and alternate. The first line and the best drug nowadays is ceftriaxone 250 milligram IM as a single dose. Only one dose, and this is sufficient, and the patient will be cured. The other options is cefixime 400 milligram, also single dose. Cefixime and ceftriaxone in urinary tract infections and not sexual and not gonorrheic infection should be given for 2 weeks. But here in the gonorrhea, only single dose, one injection ceftriaxone or one tablet cefixime, and this is enough. Any patient who is having gonorrhea, we have to consider that he is having in addition chlamydia. So it's advised to add azithromycin or doxycycline to ceftriaxone or cefixime. Example, we can give ceftriaxone single dose to treat gonorrhea and azithromycin 1 gram per oral single dose for managing chlamydia. Or we can give ceftriaxone as a single dose and we have to add doxycycline 100 milligram per oral BID for 7 days. This azithromycin and doxycycline are added to the treatment to treat chlamydia. As I mentioned, patients with gonorrhea are usually having on the same time chlamydial infection. So we have to give them this antibiotic, ceftriaxone plus azithromycin or ceftriaxone plus doxycycline, cefixime plus azithromycin, cefixime plus doxycycline. As alternative, we can give ceftriaxone 500 milligram IM, cefotaxime 500 milligram IM, or spectromycin 2 gram IM. These all can be given as a single dose. And these drugs, these alternative drugs, only to treating gonorrhea. Chlamydial antibiotic for chlamydia are azithromycin and doxycycline. The why gonorrhea should be treated? Patient with gonorrhea, male patient with gonorrhea, can develop complication or can be complicated with the following: epididymitis with sterility. Consequence of epididymitis is sterility. Patient will be sterile. Second, prostatitis, infection of the prostate. Third, edema of the penis. Periurethral abscess, abscess of Cooper's gland, seminal vesiculitis, and this all can cause sterility. Disseminated gonococcus infection. Disseminated gonococcus infection, that means the infection will not be localized in the genital organs, but it can affect also other areas. And the most common area that can be affected is the joints. Gonococcal arthritis. Patient with non-treated gonorrhea can develop later on gonococcal arthritis. The other topic that we will discuss here is the syphilis. Syphilis, it's called also a sexual transmitted disease, but it can be also transmitted by other way, like by blood transfusion. But it is counted as a sexual transmitted disease. Previously, syphilis were very common in European countries because it was no treatment before the penicillin era. Many patients, thousands, millions of patients are having or previously are having syphilis. And syphilis, as a definition, is a chronic systemic infection, and the main cause of syphilis, or the cause of syphilis, is the bacteria called Treponema pallidum. Treponema pallidum. And typically of syphilis disease, that is characterized by episodes of activity with periods of latency. And each period of activity has its certain clinical manifestations. And periods of latency, that mean symptoms-free period. And this can last for years. So many patients with syphilis only recognizing that they are having syphilis only when they got neurological problems after about 15 or 20 years, 25 years of infection. We will divide the clinical manifestation of syphilis to three: primary, secondary, tertiary. Primary syphilis, secondary syphilis, tertiary. And this is very important to know in which stage is the syphilis, because of the management, because of the treatments. Primary, secondary can be cured, can be easily treated. But tertiary, if patient has developed tertiary neurosyphilis and neurological organs has been affected, it's in general or usually it's irreversible. What are the clinical manifestations of primary syphilis? The clinical manifestations of primary syphilis, typical in the males, we will discuss here in the males. In the males, the patient are having single painless please consider that this ulcer or is painless, single painless babule, single painless babule, where in the penis, mainly in the glans penis, anatomical area of the penis. And this babule will be then ulcerated, ulcerating with cartilaginous consistency on the edge. Then vellus babule, then ulcerated with cartilage edge and still vellus ulceration. Typically, the localized in or on the penis. In homosexual, it will be also an anal chancre, and this called anal chancre. This ulceration called chancre. In association to this painless ulcer called chancre, there is regional lymphadenopathy, and when the patient is having ulceration on his penis, the regional lymphadenopathy is inguinal. Regional lymphadenopathy is the inguinal. And this regional lymphadenopathy appearing about around 1 week of the lesion onset. So, summary of the clinical manifestations is single painless ulcer called chancre, painless chancre, associated with regional lymphadenopathy, and usually it's inguinal lymphadenopathy. This chancre will heal spontaneous even without medication, but only the chancre is healed. The syphilis is not cured. Patient still having syphilis, but the chancre will disappear, will heal with around 1 month, 4 to 6 weeks, in this range. And the patient then becomes symptom free, and he will not recognize any clinical manifestations. That means not that he has been cured, no, the symptoms have been disappeared, but he still having syphilis, and this syphilis will be here, see the slide, typical chancre on the penis, painless ulceration called chancre. Here chancre can be also affected in area, even the mouth, the lips. As I mentioned, primary syphilis or the clinical manifestation of primary syphilis can be healed, but the patient still having syphilis, and after a period of time, the patient will develop, after a period of time with free clinical manifestation, the patient will develop what is called secondary syphilis. Secondary syphilis is typically characterized by mucocutaneous lesions. And here we have to differentiate. Look, mucocutaneous lesion on the palms, on the trunk, and associated, at the same time, it's associated with generalized lymphadenopathy. In primary syphilis, it's regional, inguinal, but in the secondary syphilis, it's generalized lymphadenopathy. About 10% of patients with secondary syphilis has what is called condylomata lata. Condylomata lata, condylomata, like warts. But this is not the viral warts that we know. This called condyloma, the warts, the normal warts, viral warts called condylomata acuminata. But here it called condylomata lata. We cannot only differentiate between them both types only by histopathology. But if the patient is having mucocutaneous, generalized lymphadenoma, and warts, condylomata lata, that means this is related to secondary syphilis. Not all patients with secondary syphilis will have condylomata lata, only about 10%. But secondary syphilis characteristic by mucocutaneous and generalized, not local, generalized, non-tender, painless lymphadenopathy. Here, typical feature of mucocutaneous lesions on the palms and soles area. Here is typical features of mucocutaneous lesions on the trunk. This is what I mentioned before, condylomata lata. Warts, like warts, but histopathology, it is different. The patient can, or this mucocutaneous lesion and the lymphadenopathy can be healed and disappear after weeks and months, and the patient will be symptoms free. Secondary syphilis will be followed by what is called latent syphilis. It does not mean the patient is not having syphilis. He is having syphilis or she is having syphilis, but it's symptoms free. And this symptom free of latent syphilis can be lasted for years, long period of time. What that mean, latent syphilis? Latent syphilis, the patient is having syphilis manifested by positive serological test. When you check this patient serology, VDRL example, it will be positive. But his CSF examination, cerebrospinal fluid examination, is normal. That means he has not passed to developed tertiary syphilis, or he has not developed neurosyphilis. He has not developed neurosyphilis. When the patient is having positive serological test without any clinical manifestation, and his CSF, cerebrospinal fluid examination, is negative, is normal, is negative for syphilis, that means he is having latent syphilis. So positive serology, no clinical manifestation, and normal CSF examination, latent syphilis. After periods of years, the patient will develop tertiary syphilis. And this tertiary syphilis is divided in two types. The first one is called asymptomatic neurosyphilis. The patient has passed to neuro. The neurological system has been here affected, but still symptoms free. How can I know that? I will know that the patient is not having any symptoms of syphilis, but on the same time, his serology test is positive and CSF is abnormal. In latent syphilis, he has no symptoms, CSF is normal, but serology is positive. In asymptomatic neurosyphilis, no symptoms, but serology test is positive, CSF is abnormal. And this patient who are asymptomatic neurosyphilis, later on, in around 10 years, will develop symptomatic neurosyphilis. As the term says, symptomatic neurosyphilis, that means the patient is having neurological symptoms. Neurological symptoms here can be divided in three types. So, summary of symptom neurosyphilis. Symptom neurosyphilis, the patient is having positive serology, abnormal CSF, and neurological symptoms. Three criteria should be fulfilled here to say that the patient is having symptomatic neurosyphilis, because symptomatic neurosyphilis in general or usually are irreversible. What are the subtypes of symptomatic neurosyphilis? The subtypes of symptomatic neurosyphilis are meningeal, meningovascular, and parenchymal. See, meningeal, from the term meningeal, that means the menings are affected. And when the menings are infected or inflamed, the patient will develop meningitis clinical manifestation. So, headache, nausea, vomiting, and neck stiffness, like any other meningitis. When the patient has developed meningovascular, that means meningitis with vascular involvement, the vessels has been involved. So when the vessels are involved, there is vascular involvement, and that means the patient is having CVA clinical manifestation. Exact like in a stroke patient. Stroke patients are having cerebrovascular disease. And also in this case, when the patient has developed vascular syphilis, he will have the clinical manifestation of cerebrovascular disease like stroke. But it is due to syphilis, not due to cerebrovascular disease risk factors. The other type, or the third type, is the parenchymal. And here is the problem, the big problem, is the parenchymal involvement. Patient will have mix of upper and lower motor neural lesions. Reflexes can be hyperactive. The eye, patient will develop Argyll-Robertson pupils. Patient can develop illusion, delusion, hallucinations. So different neurological clinical manifestation. And this is under the terminology of tabes dorsalis. What is called tabes dorsalis? What is tabes dorsalis? A neurosyphilis. It's a neurosyphilis. It's a type of parenchymal symptomatic neurosyphilis characterized by ataxia, paresthesia, bladder disturbance, impotency, areflexia, extensor plantar response, loss of position, deep pain, and temperature. Different neurological clinical manifestations. Patient can have Charcot joints because of loss of sensation, ulceration, irregular, small and irregular pupils, and this is called Argyll-Robertson. Small, irregular Argyll-Robertson pupil. And the patient can also develop anytime optic atrophy. How to diagnose syphilis? We have three different, but the widely used one is the VDRL serology test. It's accounted for 78% of patients with primary syphilis are having VDRL positive, 100% of secondary are having positive VDRL, and latent 95%, tertiary 71%. So we have to know the VDRL percent. In secondary it's 100%, in primary 78, in latent 95, and tertiary 71. Treating syphilis. In primary and secondary syphilis, it's easy to be treated and it's curable, and with only one single dose. Just one single dose of penicillin G benzathine, or what is called benzathine penicillin. In the market it's called retarbine. This is the same drug that is used for prophylaxis of rheumatic heart disease, benzathine penicillin. But the dose here is 2.4 in primary, secondary, latent. Primary, Bell's chancre, secondary, mucocutaneous with generalized lymphadenopathy, latent, only the serology manifestation is positive. Here we can give penicillin G benzathine 2.4 million unit intramuscular. If the patient is allergic to penicillin, tetracycline or doxycycline 100 mg per oral BID for 2 weeks. In patients who are who are having latent syphilis, we will give penicillin G, benzathine penicillin, 2.4 million unit intramuscular each week for 3 weeks. So in patients who are having latent or tertiary syphilis, we should give benzathine penicillin 2.4 weekly, each week, 1 injection each week for 3 consecutive weeks. If the patient is having penicillin allergy, we can give in latent, we can give doxycycline 100 mg BID for 4 weeks. But if the patient is having abnormal CSF and neurosyphilis, the options here is only to give penicillin G. If the patient, so we have to consider, please be in attention here, in patients who are having neurosyphilis, asymptomatic or symptomatic, that means their CSF is abnormal, whether they have symptoms or no symptoms. The main the feature here, the main feature to have neurosyphilis is abnormal cerebrospinal fluid. We should give penicillin G. Penicillin is not of benefit. Penicillin G, and this should be given 4 million each 4 hours for about 2 weeks. If the patient is having allergy to penicillin, there is no other option. Doxycycline is not effective in this case. Patient should go desensitization and treat with penicillin. No other option. Thank you for listening. Be safe. Wassalamu alaikum warahmatullahi.